I want to say a huge thank you to you, Dr. Reinisch, for agreeing to come on the platform today. You could just kindly introduce yourself to the listeners, what you do.
I'm John Reinisch. I'm a plastic surgeon. I moved from the East Coast near Boston to Los Angeles in the 80s to become a professor at the university here and start a plastic surgery program at the university's Children's Hospital, which is the Children's Hospital of Los Angeles, one of the larger children's hospitals in our country. And I did all kinds of pediatric plastic reconstructive surgery, and also cleft lip and palate and Microtia, and developed a method of making ears earlier, not using rib cartilage. So initially, when I came to Los Angeles, I did rib cartilage reconstructions. Was never thrilled with it because of the multiple stages and because of the delay in waiting. My wife worked with me at the Children's Hospital as part of our craniofacial team as our psychotherapist. And she was the one who pointed out how traumatic having microtia can be for some children, especially if they are teased in school, and the need to wait until you're older and have enough rib cartilage in the chest became more apparent to me. Surgeons tend not to be that sensitive, and my wife is very attuned to children. So we, along with a resident of mine, developed in 1990 another method of reconstructing ears, which we've perfected over the last 34 years. And that's all I do now. It's microtia. And we have patients from all over the world. So we're able to do, on average, about 3 a week of new patients.
How did you get into the microtia field?
Well, it was just one of the things that I did at Children's Hospital. And microtia is not terribly common. I think most surgeons don't have spectacular results. And then as we developed this other method, I just became interested in improving it. We had problems in the beginning like anything else, but we've just gotten better and better. And people sort of poo-pooed it in the surgical field, even though they said, well, it does look good, but I don't think it will last. I started in children in 1991 and never spoke about it until I gave my first talk in 1999, after about 8 or 9 years of doing it, just to make sure that it was going to be a reasonable method of reconstruction. And now we've become more and more convinced of that, having done it. In fact, the other day I was in the Apple store in Los Angeles, and a patient came up to me who I had done 25 years ago, and his ears was pretty good.
That's amazing. So for the purpose of the listeners and viewers, could you just explain what the difference is between the rib cartilage surgery and the MedPour surgery, and why you prefer using the MedPour as an option?
Yeah, that's a very good question. So I don't like to call it MedPour, although MedPour was the first implant. In fact, I still use some MedPour, but most of the implants that we use is not MedPour. MedPour is a commercial name for the first company that made the material. The material is all the same. It's a porous polyethylene. Polyethylene has been used in the body in various capacities since the 1950s. Interestingly, I happened to go to college in a small town in New Hampshire, Dartmouth College, and that's where the rib cartilage reconstruction started. Dr. Tanzer was a plastic surgeon there. I worked in the hospital when I was in college and met him. And before the 1950s, there was really no good method of reconstructing ears. And he had 2 boys that he had operated on. He did 5 surgeries in the 1950s. And in 1958, he presented his results and got a standing ovation at our national meeting in Chicago. And then published a few months later, in January of 1959, the article that everybody refers to. And that was the first description of making ears using rib cartilage. He did it in a number of stages. And over the years, people still do the same surgery, but but have made the surgery less arduous in that it's not 5 surgeries, it's sometimes 4 surgeries or 3 surgeries. And a Japanese surgeon, Dr. Nagata, tried to do it in 2 surgeries, which is often the case, but often there's a little touch-up. And I've done those surgeries. I'm probably the only surgeon who's done both methods. The rib cartilage does quite well underneath the skin. And so with that method, you take cartilage from the rib cage, wire it together to make an ear framework, and then slip it under the existing non-hair-bearing mastoid skin, or the skin where the ear should be, and suction the skin down over the rib cartilage. And then you have a flat ear, but you have a shape, and then you come back and do various things to try to get it to stick out more, to try to make a little sulcus or groove behind the ear so you can wear glasses or masks or wear your hair behind your ear if you wish, and try to make it look like a canal and a tragus, which is that little flap in front of the canal. And those are little smaller surgeries, but require additional procedures. In general, if you do the reconstruction early, you get a deformity of the chest. And so with time, most people have made the surgery later to get less of a deformity. So most surgeons are doing it closer to the age 10. I've always felt, probably from my wife, that it's important to go to school with 2 ears and not be teased and feel normal. So with the method that I developed, we have a framework that's not made of rib cartilage, but made of this porous polyethylene. And when we first started doing it, we would put it underneath the skin, similar to the way that you use rib cartilage, but it's not tolerated nicely under the skin. And sometimes the skin will wear a hole, or the implant will wear a hole through the skin.
Oh,
We
wow.
learned that early. And we've learned that if you cover the framework with a little layer of fascia, which comes from the side of the head underneath the scalp, you don't even know where that we've taken it. It does much better. Then the skin will glide over the implant, like the back of the skin on the back of your hand. You can wiggle it around. So that's what is important to make it survive and stay intact for many years. So when in 1995, I think we learned that, and we started covering the entire implant with this little layer of movable tissue, and then under the skin, and it's done much better. And that's what we do. With the rib cartilage, you spend most of your time making the framework, whereas we spend most of our time not making the framework, but raising this little layer of tissue from underneath the scalp without a scalp incision. The 2 methods are in good hands, can look quite good. I think the MedPour tends to, we call it MedPour, but the porous polyethylene implant method, I think, looks better, sticks out, and it doesn't hurt. So we do it not in the hospital, but in a surgical center, so children can go home, or adults. We have a lot of patients who've had rib cartilage and haven't liked it, and we change it and do a rib cartilage surgery. I take their rib cartilage surgery and redo it with an implant, and that's not a very arduous surgery. Most people who are not happy with rib cartilage surgery don't want to undergo another rib cartilage surgery again. But doing an implant surgery is not very uncomfortable, and so there's no reason to stay in the hospital.
If you do the rib cartilage option, they usually will slot it on to the side, and they will use a skin graft. With the MedPour version, where do you take the skin from?
Well, with the MedPour, so with the rib cartilage that you were talking about, you come back and take a skin graft and put it behind the ear, which is flat, and try to make a sulcus, a groove, and line that groove with a skin graft. With our method, we take the implant, which is already sticking out, and we cover both the front and back surfaces of the ear and shrink wrap that tissue around the implant. So the implant has a layer of living tissue over the non-living implant. And then we put skin over the front and back of the ear. The front side, the outside, we want to be the same color as your earlobe and your cheek. So we take the skin that's available, usually in front of the hair. If their hairline is very low, we might take a little skin from behind the other ear so that it is the same thickness and it tends to be pinker.
Okay.
Then in the area behind the ear, which doesn't show, we take skin from the groin crease, which is the area between the body and the leg. We take a full thickness skin, which means we take something that looks like a football shape, and then we close it. So it ends up being a line in the crease. When you're sitting down, you have a crease between your leg and your body. That's where that little scar would be. And that skin tends not to be as pink, but it's hidden in the back.
So the whole process is start to finish. So let's say I'm a new patient and I decide I would like to go down the MedPour route with you. What does that whole process look like to someone who doesn't know anything about it, that might be considering going down that specific route?
Yeah, so I just talked to somebody before this podcast from Saudi Arabia with a 3-year-old, and many of our patients come from other countries, so we don't see them ahead of time. We Zoom with them or do a video conference with them several times, and then they come the day before surgery. And assuming that they're healthy and don't have any other medical issues, which is true of 98% of children, we like to do the surgery before they go to school. So we operate on 3 and 4-year-olds. We've done 60-year-olds as well, but
Wow.
Many of those patients have been, occasionally you have a patient who's never had their ear fixed, but most of them have had unsuccessful ear reconstructions and have never been happy with their ears. But for the child, we don't need any blood tests. We like to have a CT scan to make sure there's not a skin collection where the body tried to make an ear canal. That's called a cholesteatoma, and that occurs in about 3% of children with microtia. So we want to rule that out, and we also want to see if they're a candidate for having a canal. If they are, then we can make a canal and an ear together at the same time. We call that a CAM, a combined atresia microtia reconstruction. We've been doing that since 2008 was our first one in January. But then the surgery is done as an outpatient, meaning that you have the surgery. We make everything numb. Since we're not taking cartilage from the chest, you can make the area where we take the skin or place the implant numb with an injection. So the level of anesthesia, even though the children are asleep, is not deep. And so at the end of the surgery, which usually takes around 6 hours, they can go home within 60 minutes. They go home with a little cute dressing. We don't use drains.
I hate the drains.
Yeah,
They're really painful.
I used drains initially, and we stopped doing it. I remember the patient was from Australia, and I usually took the drains out at 2 days. And we did the surgery on a Friday, and I said, I'll see you on Sunday and take the drains out. And then I realized it was a holiday weekend, and I was going to be out of town. And I said, why don't you drive up to Santa Barbara, where I am now, and I'll take it out. We have a condominium there. It's a pretty drive. It's only 80 miles from Los Angeles. And they said, well, we would, but we're nervous about driving on the wrong side of the road because we're from Australia, like you are from England. So I took out the drains at the time of surgery, and she did fine. And since then, that was in I think 2009, we haven't used drains after surgery.
Can you just tell the viewers what the drain's for?
With the surgery, with the cartilage surgery, you place a drain underneath the framework, which is slipped underneath a pocket in the skin, and then you're shrinking the skin down over the cartilage framework. We do
Okay,
the
that's
same
it.
thing. We put a drain in and shrink the membrane that we've placed over the implant, and we use it to shrink that down, shrink wrap around the implant.
Mhm.
Then we put a silicone mold onto the implant at the end of the surgery, and then we take the drain out. So at the
Okay.
end of surgery, there's really nothing for the parents to do. They can go home. If they're in the United States, they can go home the next day. We see them the next morning just to make sure everything is fine, and then they can fly home. But we want to see them back 2 weeks later. That's when we take off that silicone mold, which we've sewn in place, and we look at the ear, and we can tell if there's any problems. But after 2 weeks, people can go home. Yesterday, I spoke to somebody from Saudi Arabia that went home 2 weeks later, and we just did a little Zoom call just to make sure that he was doing fine, and the parents were washing his ear, like we'll teach you at 2 weeks.
Why do you put the silicone on top of the ear? So you've obviously got the MedPour is in place, the skin graft is over the top, and then do you put silicone on the top of that and
Yes.
dress it? What's the reason for that?
So in the past, early on, and many of the things we do now, we've just evolved and learned with our mistakes. We've learned how to make things easier. So in the past, when we would put this membrane over the silicone and then put our skin on that membrane, we would get a lot of swelling.
Okay.
And we've learned that if you put the silicone in place and keep it for 2 weeks, sorry,
That's okay.
there's much less swelling.
Okay. And so you're saying that you like to see them the next morning, and then they fly home, and then is that it? Are they done or okay? So so you were saying that once they leave the hospital after the surgery, they then see you the next day, and then is that it?
No, then they come back at 2 weeks, and we ourselves want to remove that silicone dressing. We wash the ear, we wash the hair. We show the parents, if this is a child we're talking about, how to make a new silicone. It's like Play-Doh. So they can mix it and then apply it to the ear. We want them to wear that at night. So during the day, after 2 weeks, you don't have anything on your ear. But at night, especially with children who toss and turn and can sleep on the ear, we don't want the ear to become flattened. We want it to stay out. And so we've learned if you wear a silicone splint on the ear for the first 2 weeks, for the first 4 months, after 4 months, you don't need it. The silicone makes a nicer scar. Silicone is often used for scarring. It prevents the ear from sort of moving toward the head, especially in young children who aren't going to be very careful about how they're sleeping.
So with the rib cartilage surgery, what they tend to do we're talking stage 2, is usually they take a piece of cartilage and they put it behind the ear to raise the ear, and then they put the skin graft over that. And with your method, you're saying that there's a piece of silicone that goes behind the ear, which then stops it from going back. So it creates that space that we all have behind the ear. Is that correct?
Yes. I mean, it's just something that we do at night, and then you take off in the morning. And we do it. Yeah. And we've just found that the ears remain sticking out. So we try to match the projection of the ear to the other side.
Okay. And are there any risks and complications with any of this?
Well, with any surgery or with really any endeavor, that nothing is perfect. So I think I've been doing this for 30 some years, and the difference is that 30 years ago, I got some beautiful results, but they weren't as frequent or as consistent as I get now. Now we are just more consistent, and just having done it so often, we're just quite good and confident in how we do it. We're quicker and have just made it easier for the family and for the children.
I just wanted to quickly go back because earlier you mentioned that aside from doing the microtia surgery, so to obviously create the shape of the ear, but you mentioned that you can also do a surgery for the ear canal. Could you just expand a bit on that, please?
Yeah, so most patients who have microtia don't have a canal, which we call atresia, oral atresia, or they may have a very narrow canal, which we call oral stenosis. But usually they don't hear well. They have a conductive hearing loss. That means that they're not deaf, but their level of hearing is considerably less than it is on the normal side. And what it means in practical terms is that in the past, we didn't worry so much if you had one-sided microtia, because if you hear well on the other side, you can develop speech. And so most people, let's say 20 years ago, who did ear surgery or ear, nose, and throat surgery didn't think it was essential to make a canal or to hear on both sides. But over the last 10 or 15 years, we've realized that it is quite important to hear on both sides if you can, for several reasons. And it's important to hear early because just like learning language or playing sports or playing a musical instrument, the brain does much better with those endeavors as well as hearing if you have hearing early. So the issues that patients with microtia have are, and it's interesting because many parents would say, well, I have a child with microtia and he seems the same as his older brother. But you begin to see things as you get older. The first thing you notice with a child is that they hear perfectly well at home, but if you're out in the park and someone calls them and you can't see where the sound is coming from, they sort of look around because they don't have direction of sound. So you have to have two good functioning ears for the brain to develop direction. And by the way, I think most people think ears do the hearing, but they don't. It's the brain that hears. The ears are simply converters of sound waves, of mechanical sound waves to electrical impulses to the brain. That's what ears are converters. And it's
I didn't actually know that.
And the brain is the computer that calculates the direction. So it can tell I'm hearing a sound a nanosecond sooner and louder on my right side than on the left. So I know the sound is coming from the right.
So clever.
That's the first thing you notice. The other thing that brain does is it does noise cancellation, just like noise cancellation headphones. So in a noisy restaurant, I can talk to somebody with a loud music and lots of talking, and I can hear them better with two ears because my brain can sort of suppress the surrounding noise. If you have microtia and don't hear as well on one side, your brain doesn't develop that capacity. And so people with microtia who've never had sound correction early find it difficult to hear in noisy situations. And
that's
they find
me. Welcome to my world.
Yes.
So,
and then it continues. So around 7, children start turning their head. It doesn't happen before that. But if you talk on the right side, and microtia is more common on the right side, if you're talking to somebody if you're sitting at a table and the person next to you is on the right side, around 7, when someone talks, you typically hear with microtia at around 65 or 70 decibels, but speech is around 40 to 50. So you hear something, but not well, and you learn that if you turn your head, your good ear is now facing them. Because if someone is talking to you on your right side, the sound, you hear something, but the sound goes over your head and it misses your good ear because your head is in the sound shadow. Your head is casting a shadow. But if you turn, and I don't really know why children don't learn this until about 7, but they do. Maybe it's just not important what they're hearing before that. But they start turning their head, or they try to position themselves so that their good ear is next to the person that they want to speak to. So that's another issue that you find. And then with driving, in England, if you have left-sided microtia, and England is perfect for people with microtia on the right side because you can talk to your passenger with no problem. But in our country, in the United States, and in most of the world, people drive on the left side, so your passenger is on your right side. And if they're talking, you can't talk to your passenger without turning your head and leaving the road. So that's another issue. And then sleeping, most patients who have microtia tend, when they're older, adults, sleep on their good ear because it's quiet. But it means they don't hear alarms or their own children crying as easily because their good ear is being covered up.
So fascinating, isn't it? Is there anything that can be done to, if, say, for example, you don't have an ear canal, and I know that you said you can obviously do the reconstruct the ear itself, but is there anything that can be done for the canal to improve the hearing, or is it just for a bone anchored hearing aid to be put on the back?
So yes, so bone anchored hearing aids have been around for 40 years and have improved, become digital, become smaller. And I work with several surgeons who make ear canals and do it frequently enough that they're quite good at it. So not everyone can have a ear canal. So patients with microtia almost always, as much as you can say always, have a normal inner ear. And the nerve from the inner ear to the brain is normal. And you can test that with an audiogram. What they don't have is a canal, and they don't have an eardrum. So the outer part of the hearing mechanism, the canal and eardrum, is not good, not developed. The inner part, which is the cochlea and the nerve going to the brain, is normal. And between the two is the middle ear. The middle ear contains the 3 little bones, and it's also connected to your throat through the eustachian tube. So when you fly and have pressure and you swallow, you can relieve that. That can vary from being very good to being very bad. And the only way to see the middle ear is with a CAT scan. So we recommend, when children are 2 or 2.5, getting a CAT scan, because it does 2 things. We can see if that little skin tumor is present, which is only 2 or 3% of the time. But we can also give an assessment of how good the bones are in the middle ear. And if the assessment is good, and we rate the middle ear with a score. So if the score is 8 or 9, never 10, because you get a point off for microtia, but you could be an 8 or 9, then you have a pretty good chance of getting almost normal hearing.
Wow. And how have you done that for someone before?
We've done hundreds.
And it's all successful?
Not always successful. So where we really love to see this is with patients who have 2-sided microtia. And we have lots of videos of this, but patients who have 2-sided microtia, the next day when we see them, and they've grown up wearing a hearing aid all of their life, almost 90% of them will say, I don't need it the next day, even though they have packing in their canal and that silicone mold over their ear, which has to minimize their hearing. And their canal isn't healed yet. And yet they don't want to wear their hearing device.
Because they can hear not perfectly well, but more than they could with the bone anchored hearing aid.
And they like natural hearing. So we see that frequently. Over time, we don't know this, how well it holds up. We did a study 2 years after these patients had surgery, and it was quite good. About 80% of them who had a score of 8 or 9 were hearing almost normally.
Wow, that's amazing.
With the 8 and 9 score, and about 2/3 of them were hearing quite well with a score of 6 or 7. We are now doing a long-term study to see how well that hearing has held up over time. So hopefully in a year we'll have better information about that. So many patients who've had canals early some of them have ended up wearing hearing devices later.
I'm looking at the time and I know I'm conscious because you have another call. So I just wanted to quickly ask you a few questions. If someone listening was deciding to consider the possibility of Microtia reconstructive surgery, what advice would you give to them? Keeping in mind that this platform is not to promote surgery, it's to inform the listeners and the viewers of their options and to educate and just explain what the options are. What would your advice be to them?
Well, I think parents have choices, obviously. They can choose not to do anything. And children can do well, but can also be teased, and you can't predict the future. So we see children or adults who just keep hair short and have microtia, and it doesn't seem to bother them. But most children end up wearing long hair and sort of conceal it. So one option is to do nothing. Another option is to use a prosthesis, which is a siliconed ear, which can look very good. That's applied either with glue or eventually with some kind of magnet or abutment, which is a little clip that you can clip onto a metal screw that comes through the skin. And those can look good, but you have to take it off and put it on. It's like false teeth. So from a self-esteem point of view, it may not be ideal for children, but for a cancer diagnosis in an older patient, it may be a good option. And then there's the rib option, and then there's the implant option. So those are the 4 options. I think you can have good, you can get good ear reconstruction with different methods, and it's more dependent on the surgeon than the method.
That's very true. And I actually did some research on you. And am I correct in saying that you've trained over 200 surgeons from 25 countries?
Well, we've had about 200 surgeons come to visit and watch surgery, but I hate to say that we train them because they can't scrub in and you have no way of knowing how good they are. Some can be excellent, and some of the surgeons get very good results, and some surgeons don't. And I have no way of certifying that. We have trained fellows, and then the people who from this country who spent a year with us, you can tell how good they are. Some are good and some aren't good. It's like anything else, I think. It's probably the same thing for people who cook.
Yeah,
you can follow the same recipe, but it may not turn out as well.
I've also got on here, it says career highlights. It also says author of Modern Microtia Reconstruction and of 100 scientific papers.
Well, I'm older, so we've written lots of papers, and the book that we wrote was really about ear reconstruction. We had someone from England write a chapter about rib reconstruction, and we talk about hearing as well in that book. That was probably 3 or 4 years ago that we wrote it.
And you met with Dr. Sabag, didn't you? Didn't you say it was 8 years ago? He came to see you
so
from
Wale
London.
Came to watch the method, and He came with Ken Stewart from Edinburgh. The two of them came together, and I know we were arguing about the age. I remember this well because they left to go back to the airport on a Thursday. I think they were here to watch surgery on a Tuesday, Wednesday, and they left. And about an hour after they left, I was seeing patients in the office, and a boy came with a hoodie on, and he had microtia. He was about 12, and he had refused surgery when it was offered to him at 10, being nervous because children around 10 and 11, you can't make them have surgery. And so the idea of having surgery is frightening for some children. And yet he was waiting in the summer in our waiting room with a hoodie on. And at any rate, we ended up operating on him probably when he was 13. And he had some asymmetry of his face as well. And we often will put fat in the cheek to make the face look more symmetric.
Is that associated with microtia, that one side of your face is not as symmetrical?
Yes.
Why is that?
Well, because microtia, even though we often say, well, this is an isolated case of microtia, it's never isolated. It can be, and we did a study, about 78% of people have very symmetric looking faces, although if you really took pictures of two rights and two lefts, they would look different. But it's not noticeable. But about 21 or 2%, it is slight. There's a slight difference. Sometimes there's a very noticeable difference. And the jaw on that side tends to be slightly smaller, and the soft tissue or the fat and muscle tends to be slightly smaller, or can be. And sometimes the eye can be smaller, and sometimes the nerves don't function quite as well on that side. So there's a spectrum of microtia, for a very mild microtia to very severe, and somewhere along that line, everybody fits. The majority usually have just the microtia, but you can have a very small eye, or we operated on a girl last week with no eye on that side, from the Middle East. And but in general, we try to make the face symmetric and try to do as much as we can in one single surgery. So we did, I think, you can also have a little longer mouth on that side, which we call macrostomia. So the girl we operated on last, on that girl, we put fat in her cheek, we put in a hearing device, we made an ear, we did something to raise her brow, which was low on that side. We closed her macrostomia. I'm trying to remember all the.
How do you close the macrostomia?
Well, you just make the corner of the mouth move in a little bit. It's quite small surgery.
So interesting. I could talk to you for hours about this. But I know we had.
This is all I do, so we're quite passionate about it. That's why I do these Zoom calls on Sunday morning.
That's why I'm delighted to have you on the show. And just here's another fun fact. And I know you'll say you're very modest. If you Google best microtia surgeon in the world, you pop up, because I found it.
I don't know that. I don't know.
Well, that's what Google says. Listen, I can't tell you enough how grateful I am to be talking with you right now, and also on behalf of the viewers and the listeners, how grateful they will be, because I do think that, and you know this as well, that anyone who's on a microtia journey, trying to decide what to do as a parent or an adult with microtia, making the decision is not an easy one. But I really hope that this platform helps, and certainly our talk today, because the advice that you've been giving and the information is so incredibly valuable. And one of the issues and the reason why I created this platform is because there's nothing really available in terms of real life human stories, and bringing on experts in the field, like in your case, to really help people make that decision. So I'm really grateful for your time today. And I just wanted to quickly ask you, if the viewers and the listeners want to get in touch with you, which would be the best way to contact you?
Yes, they can email me. I'm happy to. We don't charge for these consultations. My email is jfr, like John Frank Robert 654 at Gmail. And we send them a form they can fill out information, send pictures, and then we arrange. On Sunday mornings, I talk from 6 to 12.
Oh, wow.
Anyway, but as you were saying, I think it's wonderful what you're doing, because for most surgeries, parents don't have a choice. You need to have your tonsils removed, or you have an appendicitis, or you have a broken leg, and it takes the burden off of the family. But with something totally elective, where it is their choice, it's very important to try to make the surgery as easy and painless for both the family and the child. And we have evolved to do this. When I was doing cleft lip and palate surgery, I did it. I think I was the first surgeon who did it as an outpatient, just to make it not a big deal. And we try to do the same thing with Microtia. It's just not a big deal. You don't have to spend your time in the hospital. You don't have to have drains that you have to change. It's really quite easy. People come and go to Disneyland a few days after surgery. So we try to make it easy and not a big thing.
I think it's amazing what you're doing, and I think your vision is wonderful. And the fact that your goal is to make it as easy and as painless as possible, and just help that child have an easier, happier life.
Well, that's why we do what we do. So thank you for inviting me for this podcast. It was a pleasure to speak with you.
We will speak again. I will link everything to your email on the show notes below. And thank you so much.